we must also understand what the patient wants. And there it's very imperative, it's imperative for us to understand what is the patient's desire for treatment, what is the patient's family desire for treatment. And is actually everything an honest free choice. There should not be pressures by which decisions are being taken. And therefore it's very important that you must be very clear that there are no conflicts of interest, especially sometimes when it comes between patients and family. And that's where counselors and everybody else has to chip in to really make the appropriate decision. And while we do that, we have to remember that the quality of life that we give to the patient is absolutely vital in one of the decision-making processes that should come to our minds when we decide. And at many times, maybe no treatment may be the best treatment. Even though a minimally invasive therapy is something very easy to do, but I must refrain from doing it if I keep in mind that the quality of life is not going to be tremendously better. And of course, the economic factor, the literacy, and at the end of it, utilization of a scarce resource has to justify the treatment selection that we do. So, with hepatocellular cancer, just continuing, now we know that we've got hepatologists, we've got radiologists, we've got surgeons, we've got oncologists, all of us there, and many of these patients would move individually, primarily into any one of these calls. But the wheel has to stay connected, and all of us have to ensure that we are looking from tumor characteristics to all treatments, right down to comfort care in the terminal stage to really optimize the healthcare strategy for patients like this. Just to talk you through prognostic factors when it comes to liver cancer, if you look at the early stage, you have liver resection, you have liver transplant, and you have simple interventional radiology methods to destroy the disease. And similarly, we have IR and other methods for intermediate and advanced stage. But very often what the patient doesn't ask and what we don't talk about is the last line on this slide, which is actually what are the percentages of curative options, what are the survivals, and what are the 5-year survivals and the median overall survivals, even in early stage, intermediate stage, and then of course the advanced stages, as you know that it would tremendously fall. And if we don't share this information, we may actually make an error in selecting which is the best way to really treat our patients. So this last line is, I think, pivotal to decision making when it comes to treatment. At the same time, you're getting advanced therapies, expensive therapies into the treatment algorithm. The very busy slide, just wanted to mention that liver cancer is actually invariably, we're struggling with two diseases. It's a bad liver and a bad cancer in a bad liver. And we have to understand a bad liver with an early cancer is equally bad in outcomes as compared to an advanced cancer in a well-compensated liver. So we must understand both diseases, and not just because I can destroy the tumor, I must offer it to the patient. If the patient, because of his bad liver, anyway has a survival of less than 6 months to 8 months, he will die because of his underlying liver disease, not because of the tumor that he's developed in it, which I have detected very early. So we must therefore then move to an overall planning strategy of which is the best treatment to really offer this patient. If you look at the options for early cancer, we can do a liver resection, you can do a liver transplant, or you can do interventional radiology, and all of them would achieve near identical results, give and take 4 to 5%. So it's a play of numbers, and therefore all of this has to be presented to the patient, and we must with the patient decide which of these methods we should use for treatment. When it comes to embolization of intermediate stage liver cancer, we have treatments in which we can do a therapy using internal radiation by interventional radiology, or we can do chemoembolization procedures to try and treat these. And we understand that that's an extremely comfortable way of treatment, and many hospitals in America have virtually converted it to an outpatient therapy. Whereas chemoembolization would have a torrid post-embolization syndrome. So we must talk to the patient about quality of life and then weigh into the final decision, not just because I can do this, therefore I should do this kind of a protocol. And always, everywhere and every time, be it a corporate hospital where I work, or for 20 years before where I'd worked in a government hospital at PGI at Lucknow, we always keep cost in mind. And if you're talking about ablation, you have a simple needle insertion and injection of absolute alcohol to destroy a tumor versus a radiofrequency ablation or microwave ablation for early cancer, transarterial therapies using chemotherapy or using radioembolization, and then of course the drugs and which way to use the drugs. Just to show you an example, here's a small tumor on the liver surface. All we did was we just put in a simple needle, hit it with some absolute alcohol, and the tumor is killed. Similarly, a small tumor on the liver surface, a radiofrequency ablation was used and the tumor is dead. A small tumor on the liver surface, a microwave ablation was used, that's just showing the needle inside, and the tumor is dead. The cost there is about 10,000 rupees, the cost here is about 2.5 lakhs of rupees. So we've got to really decide which is the best one. Just to show you examples here, not to say that any one of these was a right or a wrong decision, and there would be multiple factors at play to decide, but just to say that each treatment has options and there are good and bad outcomes, and we must therefore take it together. Similarly, in an advanced tumor or rather intermediate stage tumor, a large tumor in the posterior sector of the liver, we did a chemoembolization and the tumor is effectively gone. A large tumor in segment 4 of the liver, and using SIRT, that is the radiation form of therapy, the tumor is killed. The cost up there is about 2.5 lakhs, the cost here is about 12 lakhs of rupees. We've got to again decide which is the most appropriate for this patient. Right from what the patient wants, the quality of life given by these treatments, the number of retreatments, the number of hospital admissions, and we often forget in our very focused approach that my treatment costs this, forgetting that movement of patients, relocating patients from different cities to your hospital with families, giving up of their sources of income during the time that they are there, and then going back only to come repeatedly, should actually be taken into account to decide final costing. So as we understand that these protocols keep incorporating new methods of treatment at various stages, we must never forget the prognostication and the outcome of these treatments. One of my previous speakers talked about guidelines. So are guidelines meant to guide us, or are guidelines meant to box us into boxes into what you should do? And that's where we've got to, as individual doctors with ethics and costs and good medical practice in our mind, have to think in the guidelines and even out of it. I don't think going out of a guideline means you're committing a crime. It has to be with informed consent, full patient consent, going within the protocols of ethical and affordable medical practice, and then offer what you think is the best to the patient. And therefore, to build an IR service, we always believe that it has to be affordable. It has to be available, and like repeatedly it has been mentioned, skill sets have to be developed. We have to teach interventional radiology to our next generation. We will never be remembered for long for how good an IR doctor I was, but I think I'll probably be remembered better if I left a good number of IR doctors behind me who would actually carry on the service and specialty in our country. And to do our IR service, we have to be innovative, evolving, but unfortunately, there is one thing that really inhibits us, and that is the machines on which we work. We can be only as good as the machine on which we work. That's how we started off many years ago, using a portable C-arm and a small ultrasound. We did not even have a Doppler. That's how we currently work, and this is what we aspire to have, an angio-CT system. And I must say PGI Chandigarh here has the privilege of having this machine now. It's probably the second in the country, and I think this actually would influence outcomes of interventional radiology procedures. But we must never forget simple innovations, like we had a catheter which was not staying stable inside a patient. Rather than moving from a 500 rupee catheter to a 6,000 rupee catheter, we just on the bedside made some modifications to the catheter design and made it a more stable kind of a catheter, and therefore this patient did not have required an expensive tube. An angiographic catheter not allowing us procedures using simple steam, we are able to shape it into different shapes which would allow us to achieve an outcome which otherwise we would have had to use multiple catheters, which enhance the cost. This is actually what my table looked like, and for about 20 years, we used to try and make our own metallic stents, and then I used to solder them and weld them. And in fact, my wife was probably the unhappiest soul, because she would make me suture and stitch these stents and help me. And you might, somebody who deals in stent might be interested to see that this is a fenestrated stent that we had made more than 25 years ago, which we used in a lot of our patients. Fenestrated stents are actually being used only recently, but this is what we were doing at Lucknow for decades. So just to say that innovation and keeping costs, and virtually at no cost, none of this costs any money. So I think if we can keep going this way, we must and should and definitely will make an impact. At the same time, we must also be aware of developments. Now there are magnets there. If you have a biliary stricture that you can't cross, put in a magnet endoscopically, put in a magnet percutaneously, and this tissue here will melt and you will have a biliobilious anastomosis. This is one of our patients in which a biliary obstruction could not be crossed. So what we did was that from the liver we punctured into the stomach and did a bilioenteric anastomosis non-surgically and created a biliary bypass here. And just about a couple of months back, we had this 6-month-old baby who underwent a very complicated cardiac surgery, but then this child had bronchomalacia, which was collapse of the left main bronchus, and the surgeon just couldn't extubate him, and there was no device of that size that we could have actually helped this child with. So we found a coronary biodegradable stent, which is what we used here. So we deployed this biodegradable stent inside this bronchus, with the help of which this small baby was extubated. So you have to think beyond the box. You have to think and stretch the envelope in interventional radiology and come up with options which therefore make IR the first line therapy in a huge number of patients. Be it a bleeding annular pseudoaneurysm in pancreatitis, be it a colonic bleed there in an SMS circulation, and you can reach there. Now there are gadgets that can get us there and treat these bleeds without surgical techniques. Unfortunately, after the renal biopsy, there's a laceration there which can effectively be treated. And similarly, a post-cholecystectomy, a gallbladder surgery, unfortunately had a complication of a pseudoaneurysm which needed to be embolized. One of our endoscopic colleagues did the cystogastrostomy, and then the stent that he used endoscopically was eroding on the splenic artery, required an embolization. A cesarean section, after which pseudoaneurysm in the uterine artery circulation needs to be treated. A chest tube placed for chest drainage, unfortunately we don't know how it landed up through the liver into the heart, was also retrieved non-surgically. And portal venous bleeds, portal hypertension, massive bleeds can all be treated by interventional radiology methods. Sepsis, simple infections, be it urosepsis, a simple nephrostomy is all that is required. If it's biliary sepsis, do a biliary drainage, and then these patients have strictures because of previous surgeries, and the surgeon just can't go back in and again. So we can do balloon interventions and then do an internal drainage. After the surgery, a staple line breaks down and a very small collection, a post-bariatric surgery there, which could be lethal if it goes untreated, but CT scan guidance allows us to place drains in very small collections. Pancreatitis, massive morbidity. I think interventional radiology has virtually revolutionized and changed dramatically the outcomes and approaches to pancreatitis, where we try to stay non-surgical, and you can't overemphasize ischemia and stroke, where definitely IR becomes the first line therapy. But similarly, again, not forgetting that there are a whole bunch of diseases, and I won't go through them, where we and colleagues can actually offer treatments, and a varicocele can be done tremendously by an interventional radiologist, but so can it be by a simple surgery. And therefore, we must decide as to what the patient wants. We must never forget that before deciding which of the treatments we do. And in fact, so much so that now ablation of benign thyroid nodules has come into the treatment gamut by IR people for young ladies who are extremely concerned with cosmesis and they have a thyroid nodule. It's a benign thyroid nodule, but it's treated non-surgically. And the list goes on, and I think the most important slide, the most important part of this slide, which is my last one, is actually these dots at the extreme end, which really tell us that we've just got to keep thinking and keep innovating, keep providing, but never forgetting ethical and affordable healthcare. Thank you very much.
Question, if I think, would be discussed at the time of lunch because we are running short of time.